suprachiasmatic nucleus, and then you get the influence on the pineal gland producing the melatonin. It just shows you how these things all interrelate to each other and how they feed back on each other, okay? I gave you the reference down there, so if you want to look more at that, there were also some additional good diagrams related to this as well in that same article. High carbohydrate intake. All right, so with that you could look at, depending on where we find our patients on the continuum here, they could be hypoglycemic when they show up to us. They could have progressed all the way over towards insulin resistance, pre-diabetes, maybe even diabetes at some point. The end result here is that you've got lower glucose availability regardless of how that presents, okay? Again, that glucose ultimately has to work its way into the mitochondria. With that, you're going to run through glycolysis, your Krebs cycle, and then ultimately your electron transport chain, right? So if you're limiting your primary energy resource, then you've limited just from, think about those diagrams we talked about with the mitochondria in there, you limited the production of GABA and the production of acetylcholine. Okay. So you got that. Now here's one that'll kind of slip up on you sometimes. You're doing the right things with the patient, you give them the right support, you diagnose it accurately, and they're still having a problem, but the patient hasn't completely cut gluten out of their diet. The enzyme that goes from glutamate over to GABA is called GAD65. It stands for glutamic acid decarboxylase. But that enzyme is highly influenced by gluten. So if you did a PubMed search and you cross-reference gluten and GAD65 or just GAD, G-A-D, you would see multiple articles pop up about this. But just know that that's something that you want to look at. You can actually test antibodies to that enzyme to see if that is indeed something that's occurring. But these patients, because they are not going over to GABA and they're staying with glutamate has a higher excitatory activity. It's an excitatory neurotransmitter, I should say, higher level. It is, and it's excitatory. So these patients are going to have a predisposition to higher levels of excitatory activity versus the inhibitory activity because they can't make that transition across. Ironically, some of you may have heard of this about glutamine feeding glutamate and causing excitatory activity. This may be part of the reason that happened. In general, I don't see that being much of a problem. Our patients need the glutamine. Most of our patients have some level of gut disruption. They have some level of catabolic activity going on. The need for glutamine is generally higher than the risk associated with driving that towards glutamate. Okay? But if you do have somebody that does indeed occur with, then this might be something you want to follow up with and check on. This is actually just one of the articles I pulled just to validate that point for you. So they suggest a link between gluten sensitivity and that GAD antibody. Your nutrient deficiencies. So we talked about methylation. Methylation is going to be highly necessary or most pronounced in your dopamine pathways. But the main nutrients we're talking about there are going to be your B12 and folate. And literally what's happening is those enzymes that are responsible for those conversions from precursor over to actual neurotransmitter, they're just impaired. They're just not functioning at a high enough, an optimal level, high enough level. Your magnesium, iron, and B6, again, decreased enzymatic activity. And then your glutamine. That's going to be driven by low protein intake, increase, if you're thinking about with regards to, there's a whole aspect of this where you can look at the 4-point cortisols and you can determine where the patient needs to support their neurotransmitters based on the level of the 4-point cortisol. I'll give you an example. If you see a pattern where the patient has a normal AM, first morning AM, around noon it looks pretty good, and then mid-afternoon you see the spike, and we've all seen that, right? And then drops off in the evening, what's happened there is that patient has begun to engage their true sympathetic response. So as part of that, they're increasing their excitatory activity not only through the release of cortisol, but also through the release of norepinephrine and epinephrine. So we want to counteract that, and that's where looking at something like your GABA support would come into play. Okay, so you want to counteract that with GABA activity. GI dysfunction. GI dysfunction can come in predominantly not only through glutamine redirecting your resource of glutamine, but also through your serotonin. Again, serotonin is highly concentrated in the gastrointestinal tract. And then your assessment and treatment methods with this, the micronutrients, the hormones, those are what I kind of think are standards on this. And then beyond that, I like using questionnaires. You can see those few questions when I'm doing my history. Those are the 4 questions that I ask, and based on that, I go further if I feel like I need to, but those are my 4 core questions that I want to know about every single time. Well, when you're looking to get into some of your repletion methodology here, the things you want to think about with this, L-DOPA comes from a being called mucuna. My clinical experience with it has been that it works pretty well. You may have to dose a little higher at various points, but it seems to work pretty well. I've actually had really good success with this, with using it with like the Parkinson's patients, and I keep going back to that one because that's the most extreme example of dopamine deficiency activity. But this one really seems to work well across the spectrum. And then of course your tyrosine being the precursor into that pathway. Your acetylcholine, you can use glycerophosphocholene, you can actually use phosphatidylcholine, but you can also give the precursors. You can just use B5. Remember, B5 is used to make acetyl-CoA, which then bonds with choline to ultimately form acetylcholine. Your GABA, you can use GABA, like just straight GABA. This is probably all dependent on who you ask as to what therapeutic outcome you're going to hear that you're going to get. GABA does tend to be a little bit larger molecule, and it does have some difficulty getting across, but you can do it sublingually and get people to relax sublingually just using straight GABA. Now, there is a fermented source called pharma-GABA. That one seems to work pretty well. I can't tell you I know all the mechanisms behind exactly how that one works, but that's one that you can give a patient. That's kind of my emergency button for patients. I tell them, look, if you're running into a situation where it's high stress, you got more anxiety, take this. This is going to be what you need going into that type of scenario, right? Or if you feel your stress building, take pharma-GABA. You can get some pretty quick results with that. And then some of your more common things, like your valerian and passion flower, these are really interesting in that they're not going to change the actual amount of the neurotransmitter itself. What they actually do is improve the sensitivity of the neurotransmitter receptor site. So they're making that neurotransmitter more active when it gets to that receptor. And then things like with serotonin, 5-HTP, the one we pretty much all know, but also St. John's wort and rhodiola rosacea is another one that works really well in this category as well. So your takeaways, if you know when you're looking at your patient, if you know your basic personality and the neurotransmitter that's associated with that personality, that'll pretty much zero you in on where you need to go with that patient. And then on the back side of that, know those pathways that I threw up here. You guys see, I didn't throw that many up there. There are only like 4 of them that I threw up there, right? If you know those basic neurotransmitter pathways, when you get the micronutrient test back, when you get the hormone test back, you can quickly look at that and correlate it with the symptomatology of the patient and see if their ability to make that neurotransmitter is related to a nutrient deficiency or is it related to a precursor deficiency. And you'll know how to intervene and how to treat them. Okay? Which gives us better patient outcomes. Does anybody have any questions?
Yeah. What you do with people with combination of these problems?
You treat them with multiple supplements.
Okay.
There is nothing in this that says that a patient has to be isolated to one category. As a matter of fact, remember I started off our conversation saying most of your patients walking in the door have some degree of neurotransmitter imbalance. It's just a matter of whether it becomes clinically relevant for them or not. Mm-hmm. If they have issues in multiple categories, support multiple categories for them. Mm-hmm. Because if you look at where most of these come from, again, it's protein-based. So the potential, especially if you've got someone who has inhibition of assimilation of their proteins adequately, they could be affecting multiple neurotransmitters here. Chronic stress could affect multiple neurotransmitters here.
And then you were talking about 2 types of people who actually have the personality and may have a deficiency also, or somebody who doesn't have that personality but the deficiencies manifest anyway, right?
What I was saying with that was that we all have one of those 4 types of personalities.
Mhm.
And some people cross over,
Mhm.
have tendencies of other personalities. Most of us actually do. But we all have one that we could probably say is our dominant personality. I'll use myself as an example. I'm a dopamine personality. If I start having issues with dopamine metabolism because of precursors, because of methylation defects, you're gonna significantly notice it in the way that I interact.
Because it's your personality.
It's my personality type, right? Versus if serotonin, well, I'm not heavily dependent on serotonin. Yeah, I might, if I have it, I might be a little bit more recluse. I might not want to interact quite as much. But it's not going to weigh me down. It's not going to stop me from being who I am, right? Now, if you got a social butterfly and they have a serotonin deficiency, secondary to chronic stress, let's just say, they're going to know it. They're going to be down in the dumps. That's going to be a significantly depressed patient.
But that's why I mentioned it, that the combination of personalities, not just a problem can be combination, but I'm seeing that in those personalities there are definitely combinations.
Yes, absolutely, without question. Without question.
So now what about these patients that are on chronic antidepressants or SSRIs? What's the chance of correcting some of these issues, and how do you isolate them when they've been on these things for so long and they still have these issues?
So regardless of where they're at when they come in the door to me, I still ask those same 4 questions. I still want to know, because I need to know, even irrespective of what the medications are doing, I still want to know where my initial support needs to go with them, right? If they're on the medication, and whether they want to get off of it or whether they don't, or whether it's even a possibility for them, I'm going to bring in some type of precursor support for them, right? One of these things that we've talked about, one of those things up there. And the reason I do that, and this is most pronounced in your SSRIs, but it happens with nearly all your your psychotropic medications, is that the longer that medication is in play, the more it's going to deplete the precursor or the neurotransmitter that's working on. That's the reason that you have to keep escalating the dose. So actually, if it were efficaciously done, every time a neurotransmitter or every time an antidepressant or some psychotropic will prescribe, they would prescribe the precursor right along with it. That would be the most efficacious. We all know that doesn't happen. It's not reality, but it should be.
Well, I can say that is very true, because on our patient intake questionnaires, we have a battery of anxiety, depression questions. And then taking a meds history, you'll find the patients that are on the meds, and you can see that they've got issues with anxiety, depression before you even take the medication history, because they're flagging all these questions. Then you find they're on the meds, and it's like, well, it's not doing a good job, but we still have these issues.
Right.
So, yeah.
A lot of it, again, there's no definitive answer on this. I mean, some people just need to be on the medications.
Yeah.
Absolutely. But pretty much all patients need to have some type of adjunct with the medication to make the medication more effective for them.
Yeah. So yeah, what point those antidepressants just quit working and you start bouncing from different...
They start looking for different mechanisms of action to try to take advantage of. Yeah.
What's your incidence of low ferritin levels on your dopamine patients?
I've never actually looked at it and correlated with that, but I will tell you, I'm finding more and more iron issues. So I would guess that there would be a pretty high, I don't know, I shouldn't say high correlation, I would say there should be some correlation. I don't really know, I haven't investigated it.
And you know how some patients, when they're coming low iron, you start pumping them back up. Some of them get what you would expect is that nice, slow, gradual, I'm feeling better. And some of them walk in about 2 weeks later and go, oh my God, you changed my life. Should that be a flag that dopamine was involved in that patient? If there's a correlation between dopamine production and ferritin?
If the symptomatology matches up for it, I would say yes. I mean, that's really the only way you would know. I mean, we know it affects that pathway. You know you're not going to get from tyrosine to dopa without iron. So you know you've got to have some impact on it.
But you know what I'm talking. You know how some people have like an overly dramatic response to it.
Mm-hmm.
Okay, when I saw that, I just
and I think what you're saying is that are you turning that pathway back on?
Yes.
Yes, absolutely, you would be.
Okay.
Because again, it's not if they've got a low iron and we're seeing, let's just as our example here, if we're seeing a low ferritin or maybe a low hemoglobin, we know it's affecting other areas in the body. That was the reason I kind of went off on a little tangent there to make that point.
Okay. And I have a patient that's a dopamine patient who was previously diagnosed with a B6 toxicity and was told, now I don't know if that's accurate or not, but was told that she had a B6 toxicity which caused a neuropathy. And that diagnosis was about 6 years ago.
The only thing I can say to that is
And
that is a possibility if
it
it
happens
was.
to be that one.
It is a possibility if the B6 was pyridoxine HCl. Probably not very likely if it's E5P. I've never clinically seen an example of that. I don't know. I'm just trying to think of how you would actually diagnose a toxicity other than just clinical manifestation and drawing the correlation that the patient was on, pyridoxine HCl. Other than that, I don't even know really how you would do it. I mean, maybe just draw serum B6, and if it's skyrocketed off of there, but I don't know. I'm not a real fan of the serum markers for nutrients. I mean, they have a role, but not for just absolute nutrient status. Anybody else got a question?
Yeah, let's say you had a patient you did a spectra cell, low glutamine, and a neurotransmitter, excess glutamate, low GABA. And you suspect leaky gut due to their diet. How are you going to address that without driving excess glutamate?
Okay, my first question on that would be is what I'm looking at on lab central peripheral. Okay, if the patient manifestation is suggested that they need additional inhibitory support, then I'm not going to have any hesitation about giving the glutamine. To me, the glutamine or the dysfunction in the gastrointestinal tract suggested by the glutamine, and also if it were suggested by the case history, would trump what I was seeing with the neurotransmitter dysfunction. If I had to prioritize, if I had to, I don't want to. I had rather deal with them both at the same time, and my intuition would say that if they need the support with the glutamine, if that marker is low on say like a micronutrient test, then inherently their central availability of glutamine is probably low as well. And the reason I say that is because if you think back about the methodology on how SpectraCell is ran, it's using living tissue. So if that glutamine is not available for the lymphocytes to carry out their role, it's not going to be available for mitochondria and other cells to carry out their role either, including the neurons. Does that answer your question? Kind of.
Yeah.
Does anybody else have any questions? Can you cut the camera off for me?